Good afternoon everyone. ITF welcomes all the participants for today's NDLS session. The today's topic is Isoniazid Preventive Therapy for PLHIV, an update, and speaker is Dr. Rajesh Deshmukh. He is working as the National Consultant in WHO and Program Officer at National AIDS Control Organization, Ministry of Health and Family Welfare in New Delhi. He has completed his post-graduation in Public Health from SRTR Medical College in Maharashtra and has over 15 years of experience working as public health specialist in states of Uttar Pradesh, Gujarat and Maharashtra. He has travelled extensively across the country for evaluations and program appraisals with national and international teams. He has worked as national trainer for drug-resistant TB, TB-HIV and airborne infection control. He has represented the country in several international conferences and published articles in national and international journals. We are happy to have him here for today's session. Now I request Dr. Rajesh Deshmukh to take over the session. Thank you.
Thank you very much. Hello and welcome to all. I hope you are able to listen me clearly. In the earlier sessions regarding TB and HIV, we had discussed on intensified TB case finding at HIV and TB care settings, which included newer diagnostics and programmatic management of drug-resistant TB as well. We had also discussed regarding the airborne infection control at the HIV care settings in the earlier session. Now this session will be focused on the key public health intervention which will be rolled out shortly by the Central TB Division and National AIDS Control Program, and this is an update related to Isoniazid Preventive Therapy, a strategy for preventing TB among people living with HIV. So today basically the audience is broader audience which has technical as well as paramedical staff, some from DAPCOs, some from district TB cell and few from NGOs also. So I will be trying to simplify the topic considering the mixed audience as well as try to be more operational rather than more of technical. You are aware that India is having high burden of tuberculosis. As you see the global distribution of estimated TB incidence globally, you can see that India and some of the countries in Southeast Asia as well as China is having highest burden of tuberculosis globally. If you see the estimated HIV prevalence in new and relapse TB cases, you will see though the dark brown patches are seen clearly at the South Central African region, but India in terms of absolute numbers ranks second highest among the 41 high burden countries across globe in terms of absolute number, as you see in the global TB reports published from the WHO and globally. So India's TB HIV problem is also a high burden problem as seen in many of the parts. Some of the parts of India have same prevalence as in South Africa. So basically, as you know that the TB scenario among people living with HIV, TB is the most commonest opportunistic infection in people living with HIV, and this is the foremost cause of death among people living with HIV. As you see, the statistics in India also close to 13% of the population people living with HIV, the mortality is seen in this group as compared to non-HIV group where the mortality is 4 to 5% in India. Now, India had started the TB-HIV collaborative activities since 2001 and progressed strongly on the TB HIV part in terms of infrastructure as well as in terms of provision of services to the patients. So early diagnosis, we have reached almost 85% of the patients know their HIV status. The strong element of TB HIV program in India is the linkage with ART, and as you see in the graph, the linkage with the ART has significantly increased over the period of time, and we have almost 94 to 95% of the patients who are co-infected are linked to ART services. However, saying that although our ART rates are significant and our linkage is very strong, as you see this slide, the growing concern is actually the mortality among TB and HIV co-infected patients. You can see it is almost linear, and the static 13 to 15% of the patients outcomes, the death rates are high despite high coverage of ART, and the success rate among co-infected patient is almost 76 and 77%. So basically India is actually progressing on implementing those strategies which will zero down the tuberculosis death among people living with HIV. The WHO 2012 policy on TB-HIV collaborative activities recommends some 13 to 14 key strategies to prevent TB as well as to link TB and strengthen the TB-HIV collaborative services. We have in India implemented almost all of these key policy recommendations by WHO and UNAIDS, and we are in phase of rolling out the initiation of TB prevention with Isoniazid Preventive Therapy in these groups. So basically this is the important key strategy which will now have some impact on the death rates of people living with HIV, and we will be launching it shortly. So this session will practically cover all those things which are needed for operationalization of these strategies. The National Framework for TB-HIV Collaborative Activities in India 2013 recommends three key important areas, the 3I strategies. The first I is Isoniazid. The first I is intensified case finding at ICTC, ART and TI settings and other settings also. And the second I is Isoniazid Preventive Therapy. The third I we are strengthening at different ART center is the infection control. So Isoniazid Preventive Therapy remains an important intervention in the 3I strategy. This is also recommended by the National Technical Working Group for TB and HIV in India, as well as the joint monitoring missions which visited India frequently during the last decade have recommended the implementation of Isoniazid Preventive Therapy. Similarly, the standards of TB care in India, as you see, the document standard of TB care in India, standard 10, is related to TB and HIV infection, and it emphasizes, 10.3 emphasizes Isoniazid preventive therapy for all people living with HIV. So we are, based on all these recommendations, have progressed on implementation and moving forward for implementation of IPT at the for the people living with HIV. First of all, it is important to understand what exactly is Isoniazid preventive therapy. You know, the Isoniazid INH is a bactericidal drug, and is this drug will prevent development of progression to the active TB disease from the latent TB infection. So this is a very important and very vital drug in terms of prevention of progression to the active TB disease. In almost 50% of the adult in community have latent TB infection. So as you see, the most effective bactericidal drug INH acts and prevents the development of progression of active TB disease as well as reinfection and relapses in these patients. So basically the benefits of providing IPT will reduce the risk of development of TB in majority of the people living with HIV. There are several studies to support this evidence, and almost all meta-analysis as well as the randomized control trials done in different parts of the globe, they have suggested that IPT reduces the overall risk of developing TB by almost 33%. The range goes beyond 33% up to 64% in some of the documents referred by WHO. So if you see these studies which were conducted in Brazil, South Africa and Botswana, if IPT is provided, the range is up to 68%, and in case of ART and IPT, the TB risk with IPT, ART and combined ART and IPT is reduced to almost 80% to 97% has been shown in these studies. So significant impact when it is combined with the ART, and that is the strong benefit of provision of IPT in people living with HIV. Now to support these evidences, we had actually, on the recommendations of National Technical Working Group, the National Institute of Research in Tuberculosis, Chennai, they conducted the feasibility study in different centers, and this study also showed that IPT was found to be effective in reducing TB incidence by almost 50% under the programmatic conditions in India. So study findings concluded that scaling up and strengthening IPT will have a beneficial effect in the reduction of burden of TB among people living with HIV. So these studies and even the Indian conditions NIRT feasibility study, they have recommended several benefits in terms of reduction of risk of TB, which is more common in India. Now, who are the eligible candidates for provision of IPT? First of all, the most important thing which we will have to understand is exclusion of TB is critically important before IPT is started. So how to exclude TB, how we can rule out active TB in people living with HIV and provide IPT safely in these groups. As you have been practicing in most of the centers, the 4 symptoms for TB screening, that is in adults, cough, which is current cough, fever, weight loss and night sweats. These 4 symptoms screening, as well as in children, current cough, fever, poor weight gain and a contact with a TB case. These 4 symptoms are critical for TB screening, symptomatic screening. And if you see, there are a lot of studies which show, almost 12 studies, and this has been actually the widely used globally, the 4 symptoms combination. For if you see the negative predictive value of these, if you use this 4 symptom complex and if none of these symptoms are there, you can actually rule out TB in 98.5% of the patients. So even in combination with these, there are studies which show that if there is an X-ray evidence which is taken along with these 4 symptoms, it rules out TB to 99% of one. So negative predictive value is very high. In simple terms, if the patient is not having any of these 4 symptoms, that means there are less likely chances of having tuberculosis in these groups. So this is the first important criteria to rule out TB in addition to investigations. So what are the contraindications for IPT? In which conditions IPT will not be used, should not be used? First of all, I already mentioned you on the active TB disease. Now, in certain patients where active hepatitis is, there are signs and symptoms suggestive of this, as well as peripheral neuropathy. In these situations, at present, we are contraindicating IPT. Now, there are certain actually conditions where IPT, as I have mentioned, is contraindicated, but pregnancy is not a contraindication. Isoniazid is safe in pregnancy, so pregnant women living with HIV should not be excluded from symptom-based TB screening and should receive IPT accordingly as per the guidelines. So in pregnant women, it is not a contraindication, it is safe in pregnancy. Secondly, there are a lot of debates on the tuberculin skin test, whether it is a requirement for initiating IPT in people living with HIV. So as per the all the evidences, latest evidences, and even the WHO recommendations, TST is not a requirement for initiating IPT in people living with HIV. TST can be an additional value in certain cases like pediatric cases, but then for adults and adolescents, tuberculin skin test is not a requirement. It should not be used as one of the barriers for initiating IPT. Now, what should be the process of operationalization at the ART center? The patient flow, as you see in this slide, the patient will be initially screened. The PLHIV or CLHIV will be screened based on the 4 symptom TB screening by nurse, and as I have already mentioned, these 4 symptoms in adult: current cough, fever, weight loss and night sweats, and in children, current cough, fever, poor weight gain and contact with TB case. So if the patient is having if the patient is symptom screen negative, then the patient is sent to the ART MO for IPT assessment. If he is eligible for IPT, then the IPT will be initiated from the ART center, and the pharmacist will be providing the IPT for the patients. So in case if the patient is not eligible for IPT, then defer IPT and evaluate these patients. Now in those cases where the symptom screen is positive for TB, you will have to work out the process as per the intensified case finding at the ART center. So the same principle is followed, line list is maintained, and the patient is evaluated for TB using different TB diagnostic criteria. In case the TB is diagnosed, the patient is treated as per the RNTCP guidelines, and if the TB is not diagnosed, then the patient is referred back to the ARTMO for the further evaluation. So basically you will have to follow these initial screening at the ART center, and definitely the most important criteria is to rule out TB for initiation of IPT. Now with the availability of cartridge based nucleic acid amplification test at the ART centers, we have the advantage of getting TB diagnosis accurately at a very rapid pace. That means within 90 minutes you can get the diagnosis of TB as well as rifampicin resistance in almost all the ART centers, because we have already mapped out entire ART centers and their linkage with the CBNAAT. So in country, almost all the ART centers will have one CBNAAT in the same facility. There are certain 39 centers which are remaining, but we are finding solutions to link these patients in terms of early diagnosis. So almost all, as you see in the map, almost all these centers, ART centers, are now linked to the CBNAAT. So you have better advantage of getting TB diagnosis early and then initiation of ART, and in case of no TB, then IPT at these centers. So There were a lot of discussions and studies and debates on what should be the regimen and duration of IPT. So globally, India has also considered a lot of studies which suggest that ideally the duration of Isoniazid preventive therapy in these contexts should be 6 months, and INH as compared to the other drugs have equal efficiency in preventing TB. So in Indian context, the regimen duration of IPT as finalized by the technical experts and the technical group in adults and adolescent, isoniazid 300 mg and pyridoxine 50 mg per day for 6 months is the appropriate regimen, and the duration is 6 months in terms of India. And children, isoniazid 10 milligram per kg, pyridoxine 25 milligram per kg. So there are, as we understand, there are a lot of difficulties in diagnosis of pediatric TB, considering the actually the diagnostic modalities. You will have to diagnose TB accurately in these groups. So basically there is a significant challenge in diagnosis of TB in infants, that means less than 12 months. So any contact with a tuberculosis patient should increase the suspicion of TB in these cases. So high suspicion should be considered in terms of contacts with a smear positive case in the family. So this is very important criteria when it comes to pediatric TB as well as initiation of IPT in case of children living with HIV. So what should be the modality of IPT dispensing? At present, IPT will be dispensed from the NACP only though the provision of drug is from the central TB division. So the drug supply chain mechanism will be the same as per the central TB division guidelines. So drugs will be provided through the central TB division and subsequently will reach at the ART center. Now the dispensing at the ART center will be the pharmacist of the ART center who will be sensitized on this, and the isoniazid will be provided as per the monthly collection at the ART centers. We are now actually working out strategies to further decentralize this in terms of pre-ART care, and also considering the accessibility of the ART centers in some of the high geographical location states where you have difficulties in accessing to the ART as well as IPT. So we are considering certain strategies to improve the decentralization as well as improve the adherence to the IPT strategies, which will help to reduce the accessibility issues as well as reduce the adherence issues. So I will at present align INH refills along with the ART refill appointments wherever the ART center is providing these drugs, and pharmacist will be the key person who will be providing the IPT in the monthly dispensing. Now there are certain queries raised by some whether IPT and ART can be provided together. So there is no problem in provision of IPT and ART combined, and it, as I have shown in the earlier studies, the table which you saw, the Brazil, South Africa and other studies showed that the combined ART and IPT will have an added benefit, added impact, and will reduce the risk of developing TB in huge number of patients. So ART and IPT concomitant use is recommended, as well as actually IPT is there is no barrier in terms of immune status. So irrespective of CD4 count, the IPT is provided as in terms of ART coverage. Does provision of IPT increase risk of drug-resistant TB? This is the question which is frequently asked, and maybe there are many countries where this is created. This is considered as one of the important challenges to address and to convince the health facilities. So basically, as you see in the latent TB infection, there are bacilli which are dividing slowly. Therefore, the risk of developing TB in drug-resistant TB is not significantly associated with provision of IPT. So, providing IPT to people living with HIV does not increase the risk of developing INH resistant TB. So, therefore, the concerns related to development of INH resistance should not be a barrier to initiate IPT. There are a lot of studies to support these. One of these is Van Helsema's et al. Study, which is shown in the slide. I don't want to go into the technicalities of these, but the prevalence of INH resistance among IPT exposed is similar to the background population. I repeat, in these studies, the main conclusion was prevalence of INH resistance among IPT exposed is similar to the background population. So there is no risk of INH resistance in these patients. Now, it is very critical to clinically follow up these patients and ensure adherence to the IPT. People living with HIV and receiving IPT should have regular clinical follow up, and there should be regular screening of for TB at every encounter with the health provider. So you have to ensure that follow up clinical examination TB is subsequently ruled out regularly. It is most critical in these patients to ensure that the PLHIVs are adherent to the IPT. There are several studies globally which suggest that the adherence is a critical issue in terms of IPT. So there are a lot of studies, including the NIRT feasibility study, which concluded, as you see the interim report of the study, which is unpublished right now, the adherence is the biggest challenge in terms of IPT. So proper counseling, as we do regularly in ART, simultaneously we'll have to do proper counseling, and here the counselor's role is critical. So we'll have to ensure, in addition to that, we are also planning to have some strategies to ensure adherence, including some supportive mechanisms to see that the patient is adhering to the Isoniazid Preventive Therapy. So in addition to that, the update of TB status at every visit has to be documented, as well as we have to ensure that the proper duration and dose of IPT is adhered to. If patients are diagnosed with TB after completing IPT, there are certain chances of patients diagnosed with TB after completion of IPT. These cases are managed as per the revised National TB Control Program guidelines. So you will have to initiate TB treatment as per guidelines. So secondary prophylaxis is also recommended by WHO, in addition to wherein the patients are provided with anti-TB. Those patients who are subsequently having TB, they will be treated as per RNTCP guidelines, and also you will have to follow certain guidelines in terms of all these patients. So now the important challenge is to document all those things. Specifically, the role is more at the ART center. Recording and reporting of IPT is equally important. So NACO and Central TB Division, we have worked together what should be the recording mechanisms and reporting mechanisms for IPT in the current context. We are not modifying any new changes. drastically, but then in the existing documents you will have to ensure that the reporting and recording for IPT is done. As you see in these, you will see the clinical notes. If the 4 symptoms are negative, we at many of the centers we are using this stamp, which is having 4 symptoms: cough, fever, weight loss and night sweat will be crossed in these conditions if the 4 symptoms are negative. So almost there are many centers where the 3I strategy is piloted, and in these the cough, fever, weight loss, night sweat stamp is used. So this is to be recorded. So for the ART staff, this is important activity. For other who are doing supervision, you can always refer to these documents. In addition to that, if the you can also document at the white card. As you see in this slide, if the 4 symptoms are negative, you are mentioning that in the others column, where you will have to mention IPT as seen in the red, and in remarks also you will have to mention 4 is negative. Now I am not going into more details on the recording and reporting, because already there is some training already going on for the specific level of staff, but for the other staff to understand that we are already recording a plan for the recording and reporting of IPT at different levels. Even the revised master line list at the ART center should be updated, as you see in the screen. I am sorry for the snapshot view of this, but then you can easily see that there is a drop down menu at the IPT status, as well as the 4 symptom screening, whether it is positive, whether it is negative, or whether the 4 symptom screening is done or not done, has to be mentioned. Secondly, as you see the IPT status, whether the IPT is initiated or contraindicated, eligible but not started on IPT, and there will be subsequent things which have to be documented. Now the TB treatment status, in case the patient is diagnosed with TB, is also to be reported. As you already know that the daily anti-TB regimen will be used as a single window service at the ART center. So subsequently you will find that the same ART center will be providing ATT in the form of daily regimen, which will be rolled out shortly along with this, and the ART center will document that also. In case the patient is diagnosed with TB, he will be initiated on ART in the form of daily anti-TB treatment from the same ART center and document accordingly. If the patient is not having TB, then the patient is initiated on IPT based on whatever I have shown you as a eligibility criteria, and subsequently he will be provided IPT through the same service. So this will be actually a single window service for people living with HIV, where as per the diagnosis the patient will be provided with the TB treatment as well as preventive therapy in these situations. Similarly, there are 2 columns added in the monthly progress report sent by the ART center in terms of IPT status, which is documented from the master line list of the reporting month. So number of PLHIVs newly initiated on IPT during this month, and number of PLHIVs completed IPT during this month. So this information is also collected from the different centers during the monthly progress of on the IPT. NACO and Central TB Division have collectively worked along with the experts in the country on the operationalization, and we have developed an operational manual for IPT which includes all the details related to initiation of IPT. And if you need more details on the Isoniazid Preventive Therapy, you will find that this document is available on the naco.gov.in website in the TB HIV links. So if you go to the publications section, You will see all the documents related to TB HIV in this naco.gov.in web page. So if you want to have additional information on operationalization of IPT, please refer to these documents. I thank you for joining me in this update on the Isoniazid preventive therapy. We have actually emphasized operationalization of IPT in next few months, and we'll be getting the drug shortly. And once the drugs are received from the Central TB division, we will be immediately rolling out IPT in the entire country in one go. So I wish you all the best and try to access whatever information is available for the IPT operationalization. And if you have any queries, please mail me, or you can always ask at any point of time. Thank you very much for your patient listening, as well as for attending these webinars in such a high number. Thanks once again. There are certain questions posing out. Now there are certain points which are referred. Uh, Symptom screening to be done by care coordinator and nurse. So basically, as you know, care coordinator's role is important in for symptom screening. At the 3I sites, we found that there are added benefits of using care coordinators technicalities in asking the patients on whether the patient is having cough, fever, weight loss, or uh, night sweats. So we are using 4S positive and 4S negative stamp for care coordinators in the 30 high burden centers in the 3I project. So that is working out nicely. We see that there is an additional role of care coordinators in symptom screening as well, in addition to the existing staff who is conducting the 4 symptom screening. So if you have any questions, I see that there are a lot of staff who are joining in from different groups. So DAPCOs, as well as our alliance partners and other partners, they have also a very critical role in knowledge dissemination related to IPT to the last person who is involved in the TB and HIV care. So IPT is equally, as you know, that is very critical for prevention of TB among people living with HIV. So all the staff from the CSCs, as well as from the NGOs, from DAPCOs, from TB side, and from at the grassroots level also, they can actually help in supporting in terms of knowledge dissemination, in terms of seeing that the patient is adhering to the IPT, and it is very critical to engage the patients in terms of IPT. Thank you very much. Once again, I thank ITech for providing me this opportunity to have a discussion with you on this very relevant and important topic.
If you have any more questions, kindly post it in the chat box. I'm requesting the participants, still we have time. So if you have any questions related to these presentations, or if you want to get clarification on any of your topics related to this presentation, kindly post your questions in the chat box.